The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Okay, hello again everyone. So welcome to the second part of my lecture, which is on gynecology. So tapos na tayo sa mga gestational concerns, doon naman tayo sa non-gestational parts ng aming practice. So what I did, guys, instead of starting off with anatomy, physiology, etc., ang ginawa ko, dinivide ko yung topics into chief complaints or concerns. Okay? So ito yung magiging jump-off point natin for discussion. So ano ba yung mga usual chief complaint ng mga patients sa OPD or sa emergency room kapag gyne patient sila? So they could be coming in for abnormal uterine bleeding, vulvar lesions or ulcers, vaginal discharge, abdominal pain, lalo na sa ER, infertility, so hindi sila mabuntis-buntis, or on the other hand of the spectrum, ayaw nila mabuntis. So they come in for family planning or contraception, increasing abdominal girth. Doktora, lumalaki po yung tiyan ko, or lumalaki po yung tiyan ng mama ko. Okay, so yan yung isa sa mga chief complaints. And finally, I'll be discussing menopause. Okay, so let's start with the first index case. We have a 26-year-old na ligavid, and she came in due to profuse vaginal bleeding. So she has no known comorbidities. So since profuse vaginal bleeding yung complaint niya, you got her complete menstrual history. So ito yung menstrual history ng patient. She had her menarche at 12 years old. She's regularly menstruating, so monthly ito. Ang interval is 28 days plus minus 3 days, okay? So ang duration, take note of the duration, 10 days siya kung magregla. And according to the patient, she's bleeding heavily, okay? Before 2 pads per day, but currently 2 adult diapers na siya kung mag-bleed. However, she reports no symptoms associated with her menstrual cycle. So wala siyang dysmenorrhea, wala siyang dysphagia, dyspareunia, etc. Okay? So ang LMP niya ay yesterday. So when you say yesterday yung LMP niya, kahapon yung first day of menses niya. So today is her day 2. Okay? So ano yung una mong gagawin? Again, this is a reproductive age woman who comes into you for bleeding. So tama yung nandito, no? First, you must perform a pregnancy test. So tingnan natin. Okay. Okay, so sabihin natin nag-negative pregnancy test si patient. Doktora, paano pag nag-positive to? Di ba pag nag-positive, iba na iisipin natin? Either she's having early pregnancy complications or this disease entity, abnormal uterine bleeding. Doktora, pwede po bang PT positive plus abnormal uterine bleeding? No. Ang AUB, we reserve this for non-gestational causes of vaginal bleeding. Okay? So, or any abnormality in vaginal bleeding. Mamaya, explain ko kung bakit ganun. Alright. So, when you say bleeding, vaginal bleeding, may iba-iba tayong iniisip na cause or etiology depending on the age of your patient. So kapag medyo mas bata pa siya, ang iisipin mo, pwedeng foreign body kasi hindi pa siya nagre-regla. It could be from trauma, infection, ovarian tumors, etc. So around the time of menarche, dito na lumalabas yung mga bleeding dyscrasias dahil nagre-regla na sila. So dito na nila minsan na-discover, dito pa lang nila na-discover na meron pala silang coagulopathies. They could also have bleeding disorders from an ovulation kasi hindi pa mature yung HPO axis. So within this age group, ito roughly is the reproductive age group. Ano bang ibig sabihin ng reproductive age group? From the time between menarche, which is around this time, up to the time na nag-menopause sila. So pag nag-menopause, doon mo na iisip yung mga malignant conditions causing bleeding, alright? So, si patient natin nasa reproductive age group siya, diba? 26 years old. So ito yung mga iniisip natin na possible causes. So isa-isahin natin yan. So bago nyo maintindihan yung menstrual cycle, may isa pa akong i-introduce sa inyo na parati nyong makikita. Okay? So itong picture na to, favorite ko to. This shows you the HPO axis. So ano yung HPO axis? So H stands for the hypothalamus, the P stands for the pituitary, specifically the anterior pituitary, and O stands for your ovaries or your gonads. So this is your HPO axis. So ano ibig sabihin ng HPO axis? So from your hypothalamus, you have your GnRH or your gonadotropin releasing hormone. The GnRH, this is the one that stimulates the release of your pituitary hormones, particularly yung nasa anterior pituitary, which are your FSH or your follicle stimulating hormone, and your LH, your luteinizing hormone. So a side note about your pituitary gland, so it's divided into the anterior pituitary and the posterior pituitary. So si anterior pituitary, guys, ang hormones of concern natin dito are these two, your gonadotropins, no? Si FSH and si LH. Pero kasama niya sa anterior pituitary na nare-release itong mga ibang hormones. TSH, GH, and ACTH. GH stands for growth hormones, no? Kaya sila din yung mga magkakashare ng alpha subunit, remember? So, na-stimulate nila yung isa't isa. So, mamaya, that's an important side note, no? Keep that in mind. So, ito yung mga nare-release ng anterior pituitary. Sino naman yung nare-release ng posterior pituitary? So, ang galing sa posterior pituitary are your oxytocin and your ADH, or your antidiuretic hormone, also known as your vasopressin. So, guys, just a little clinical correlate regarding your posterior pituitary hormones, like oxytocin and ADH. I just want to say na meron siya kasing OB correlate, no? So, balikan lang natin ng konti. Si ADH kasi, your antidiuretic hormone, this is released in response to dehydration. Okay? Kaya nga siya antidiuretic. Ayaw mong mag-diurese kasi gusto mong mag-retain ng water. So, anong problema pag mataas si ADH? Kapag mataas si ADH, your oxytocin receptors are also stimulated. Why? Because these two hormones are closely related to one another. Konting ilang proteins lang ata yung difference nilang dalawa. So what happens is, if you're a pregnant patient na dehydrated, mataas ang vasopressin or ang ADH mo, na nasa-stimulate din si oxytocin. Okay? Na-get? So, sila yung mga nagpi-preterm labor. That is why we don't want a dehydrated pregnant patient. So, diba? Remember, when we have you have a patient in preterm labor, we ask them to increase oral fluid intake or we admit them for IV hydration. So, yun yung purpose niya. So, guys, just another side note, yung mga posterior pituitary hormones, they are actually secreted or produced in the hypothalamus, kasi na-transport lang sila sa posterior pituitary na nag-release into the bloodstream ng hormones na to. Okay? So, side note lang. Okay, so let's now focus on the HPO axis in relation to your menstrual cycle. So, we'll start with the early proliferative phase. So, during the early proliferative phase, what happens is there will be a slight increase in the FSH. Okay, so ito yung slight increase na yon. So si FSH, ang ginagawa niya from the name itself, follicle stimulating, is that it stimulates the growth or the maturation of your follicle. Okay, so during a cycle, it will stimulate or allow the maturation of around 5 to 15 follicles. Pero, dun sa 5 to 15 na yon, isa lang yung magiging dominant follicle. Anong ibig sabihin ng dominant follicle? Yung dominant follicle, siya yung mag-ovulate. Siya lang yung maglalabas ng egg. Malinaw? So maraming i-recruit, pero isa lang ang mangingitlog. Alright. So a note about the gonadotropins is that may kanya-kanya silang corresponding cell na sinistimulate within the follicle. Okay? So si granulosa cells, it has receptors for your FSH. So again, si FSH, this is the one that is responsible for your follicle maturation. Si Theca cells naman, ang receptors niya ay for LH or for the luteinizing hormone. So ang purpose naman ni LH is to facilitate steroid hormones production. Malinaw? So si GF at si TL. So sila yung magka-relationship. si girlfriend, granulosa granulosa cells for FSH, and si Tika cells for luteinizing hormone, GF and CL, girlfriend, true love. Okay? So yun yung mga corresponding gonadotropin with their cells sa loob ng follicles. Alright. So, as the follicles mature, they produce estrogen. Okay? So, kaya makikita nyo, nag-i-increase yung follicles during the early proliferative phase. It's because nagmamature na rin kasi yung mga follicles nyo, which are the ones that produce your estrogen. So, si estrogen, ang purpose niya is to inhibit the LH. Okay? So, kung papansin niyo si LH, diba, para lang siyang plateau. Level lang siya. Okay? Isang level lang yan si LH. Because, at this level of estrogen, siya ay may negative feedback to your LH. Hindi lang siya kay LH, may negative feedback, kay FSH din. Kaya diba, from an initial increase, magde-decrease ang FSH mo during the early proliferative phase. This is because dumadami na si estrogen. Okay? So at a certain level, so since nagde-dip tong mga gonadotropin, magde-dip din ng konti si estrogen. Pero since itong mga follicles mo patuloy na nagmamature, patuloy na nagproduce ng estrogen, magkakaroon siya ng rapid increase. Okay? So ito na, nag-accelerate na yung pagdami ng estrogen. So we now move on to the late proliferative phase. Okay, so during the late proliferative phase, what happens is, si dominant follicle, nagproduce na siya ng enough amount of estrogen, now producing positive feedback. So kanina, di ba, nagne-negative feedback si estrogen. Now, sa sobrang taas ng estrogen level mo, nagpa-positive feedback na siya. So instead of inhibiting your LH, it will now cause an upsurge or an LH surge in your luteinizing hormone. Okay? So just to make it clear, at low levels of estrogen, it will have a negative feedback to your LH. Pero at high levels of estrogen, such as what happens here, during your late proliferative phase, it will now have a positive feedback. So siya ang magkukos ng LH surge sa patients natin. So tingnan natin panandalian itong endometrial changes. So during the proliferative phase, so from the name itself, proliferation, which is caused by the estrogen, nagmamitosis yung glands and stroma mo during this time. Okay? So makikita nyo, di ba, ito kasi yung initial part niya, parang hindi mo siya ma-appreciate because nag-menstrual dito. So, nag-slough off yung endometrium. But during this time, during the late proliferative phase, mas ma-appreciate mo na siya, no, na kumakapal na yung lining ng matres mo. So, nag-proliferate na siya. Secondary to the effects of the estrogen. Alright. So, anong nangyayari towards the mid-cycle? So what happens is, di ba, may LH surge na caused by the high estrogen level. So ano bang ginagawa ng LH? So sa LH kasi guys, di ba, luteinizing hormone produces steroid hormones, di ba? It causes the production of the steroid hormone. So what happens is, nag-i-increase ng progesterone levels and nag-i-increase din ng prostaglandin levels. So the increase in the prostaglandin and the progesterone will stimulate the release or the lysis of your ovum from your dominant follicle. So ito na siya. Ito na yung nangitlog siya. Alright? Kapag meron kang LH kit, so para rin siyang pregnancy test, iniihian din siya and then it will turn out positive if you are during this surge. Ibig sabihin, you are fertile. So paano namin tinatime yan sa REI or sa reproendo? So, ina-advise namin yung patient na kapag halimbawa sa hapon, sila ay nag-positive sa LH, they have to time their coitus, okay? Because ovulation occurs about 32 hours after the initial rise of the LH surge and about 16 hours after its peak. Okay, malinaw? 32 hours after this and then 16 hours after this, after the peak. Okay, so doon namin sila ina-advise na mag-coitus during this time. Alright? So, ano nang mangyayari sa next part of the cycle? Yan. Okay, now we move on from proliferative phase to the secretory phase, or from the follicular phase to the luteal phase. Why luteal phase? Because, di ba, from the dominant hormone, from the dominant follicle, magkakaroon ka ng corpus luteum. Basically, corpus luteum is a dead follicle. Siya yung body, siya yung parang covering ng ovum before nag-ovulate. Okay? Siya yung pinanggalingan ng egg during that cycle. So bakit corpus luteum? Because it is color yellow because of the number of steroid hormones that are coming from your corpus luteum. So si corpus luteum, guys, is a temporary endocrine organ. Okay, organ, quote unquote. Sige, binilang natin temporary endocrine structure siya. So may lifespan lang si corpus luteum. Around 12 to 14 days lang yung lifespan niya. That is why this part of your cycle, the luteal phase, is most of the time constant, okay? 14 days yan. Ang variable or yung nagpapalit ng variation or ng haba is itong first part or your follicular phase, okay? So talaga yung nag-determine kung gaano ka-variable yung length ng cycle mo. Pero si corpus luteum, more or less, same lang yung lifespan niya. 2 weeks lang yan. Tapos magde-degenerate na siya. Okay? So as I mentioned, corpus luteum is a temporary endocrine structure. Primarily, ang pinuproduce niya is ito, si progesterone. So anong purpose ni progesterone? So kita niyo to, guys, from straight lang yung glands dito sa proliferative phase. Pagdating sa secretory phase, it will undergo vacuolization, no? So, secretory, magsisecrete na yung magiging coiled na and magiging spiral na yung glands mo during this time. So, bakit ganon? So, this will be the ideal endometrium for implantation, okay? Yun ang purpose ni secretory phase, which is facilitated by your progesterone. Now, aside from your progesterone, your corpus luteum also produces estrogen. So for a while, bababa si estrogen, but then mag-i-increase siya kasi yung corpus luteum mo also produces estrogen. So another hormone that it produces is your inhibin. So si inhibin, ang purpose niya is to inhibit the release of your LH, or gonadotropin. Okay? So kung papansinin niyo, pagdating mo ng luteal phase, mababa na si LH at si SSH kasi inhibitory na itong mga steroid hormones from your gonads sa mga gonadotropins nyo coming from your pituitary. Na-get? Okay. Sige. So, I'll give you 2 scenarios. So, for example, your ovum gets fertilized, diba? Dapat within 24 hours from release, ma-fertilize siya kasi otherwise, mawawala na si ovum. Ganyan, di ba? So, 12 to 24 hours, kailangan ma-fertilize upon release. So, for example, tama yung pag-time ng coitus mo, and then may sperm na nag-fertilize ng ovum, then your corpus luteum lives on beyond 14 days. Okay? Bakit? Kasi mini-maintain siya ng beta-HCG. Remember, di ba, pag meron kang beta-HCG, it means na meron kang nag-implant, di ba? May nag-implant sa iyong endometrium which causes the production of your syncytial trophoblast, cytotrophoblast. So, magpuproduce yan ng beta-HCG. And your beta-HCG will maintain your corpus luteum. So, dahil may nagme-maintain ng corpus luteum mo, ibig sabihin, meron kang taga-produce ng progesterone. Okay? So, dahil may taga-produce ka ng progesterone, magko-continue yung pregnancy. Okay? So, eventually, kapag patay na yung corpus luteum, magte-take over na yung mature enough placenta for the over the progesterone production. Okay? So, siya na instead na yung corpus luteum mag-produce ng progesterone, siya na rin magsusupport sa sarili niya. Okay? So, siya na yung magpo-produce ng hormone na magme-maintain ng endometrium niya for the rest of the pregnancy. Alright? So, yun ang scenario kapag ikaw ay nabuntis or kapag ikaw ay may na-fertilize tapos may nag-implant sa endometrium. However, what happens if walang na-fertilize na egg? Okay? So, walang na-fertilize na egg, ang mangyayari, mamamatay si corpus luteum. Okay? Mamamatay to at the end of 14 days. So, what happens is there is a massive drop of your hormones. So, magda-drop yung inhibin, magda-drop yung progesterone, magda-drop din yung estrogen mo. Okay? So because of that, because of the withdrawal of your progesterone, kaya ka nagme-mens. Kaya nasa-slough off yung endometrium. Remember, your endometrium that looks like this is the one that is responsible for this is your progesterone. So kapag yung corpus luteum that is producing this hormone is withdrawn or nawala yung corpus luteum mo, yan, ito yung magiging consequence. Magsa-slough off yung endometrium. And that will mark the day 1 or the first day of your menses. Okay? So, in a nutshell, ito na yung kung halimbawa hindi nyo pa rin maintindihan yung explanation ko, ito na yung kailangan yung maalala for the board. So basically, your menstrual cycle is divided into 2 parts. The first part is in relation to the stage of your follicle. So follicular, kasi di ba yung first stage, nagmamature, nagde-develop pa lang yung follicles mo along with the dominant follicles. The second part is called luteal phase because ang predominant doon, ang main player mo dito in terms of ovarian cycle is your corpus luteum, kaya siya luteal phase. So in terms of ovarian hormones, ang primary hormone mo is your estrogen, which is produced by your follicles. And then sa luteal phase, it's your progesterone, okay? Just note na hindi lang naman ito yung hormone na pinoproduce ng iyong corpus luteum, but siya yung predominant na hormone during this time, okay? During this part of the cycle. Now, in terms of endometrial changes, we describe it in terms of having proliferative phase, kasi nagpo-proliferate pa lang, nagmamitosis pa lang yung mga glands and stroma dito, and secretory phase. So, ito, nade-develop na further yung glands, nagkakaroon ng vacuolization na tinatawag, no? So, magiging na siyang magandang environment for implantation of your fertilized ovum. So, this, guys, in a nutshell, is your menstrual cycle. So, I hope maintindihan nyo siya. Kasi as I mentioned, a lot of our topics, a lot of our disease entities, our medications are tied to this concept. Okay? Okay. So let's now go back to our AUB topic, okay? So ito yung nasa Compre GYN 8th edition, which was released last year. So cycle length is 28 plus minus 7 days. Duration is 4 days up to 7 days. Menstrual blood loss is 35 ml, no? Up to 60 ml. So ito yung nasa book, but this is the simple definition. Kaming mga OB, we follow the FIGO guidelines. Okay, so mamaya ipapakita ko yung FIGO guidelines. But before that, may time components din kasi yung abnormal uterine bleeding. When do we say that it's chronic? So it's chronic if the pattern is persistent for the majority of the preceding 6 months. When do we say it's acute? It's acute if for us, if for the clinician, yung amount ng bleeding ng patient is sufficient to warrant or require immediate intervention. Okay? So, ibig sabihin, yung mga ina-admit namin sa emergency room for profuse bleeding, ayan, we consider those acute. Pag kailangan namin magbigay ng medication, mag-blood transfusion, mga acute bleeding yan. So, pwede ba, Doktor, acute to chronic? Yes, of course, because most of the time, your acute bleeding happens in the background of a chronic cause of abnormal uterine bleeding. Okay? Malinaw? So, di ba kanina sobrang simple lang nung sa Compre GYN 28 plus minus 7 days. However, guys, ang pina-follow ng mga obstetrician gynecologists is this system, no? The FIGO classification system. So, FIGO stands for International Federation of Gynecology and Obstetrics. And ito yung pinaprescribe nila no way. Ito yung notation nila for describing the symptoms of abnormal uterine bleeding. Now, isa-isahin natin. So, in terms of frequency, kasama na si amenorrhea sa AUB. So, before, sa mga prior classification system, hindi kasama yung amenorrhea under AUB, but now, kasama na siya. So, an infrequent cycle is more than 38 days. A frequent cycle is less than 24 days. Therefore, ang normal is 24 to 38 days. Okay? So, ito yung pina-follow namin na normal. 24 to 38 days. In terms of duration, ang normal is less than 8 days. in terms of regularity, ito guys, malilito kayo dito. So, i-explain ko siya later on. Okay? Mas i-explain ko. But ang regular natin, yung cycle variation is less than or equal to 7 to 9 days. Doctor, any cycle variation, mamaya ipapakita ko sa inyo. Si flow volume, ito I agree with Figo with this kasi hindi mo naman talaga mako-quantify in terms of milliliters kung ilan yung blood loss ng patient mo. So this one is patient determined. Si patient ang nagsasabi if the flow is light, normal, or heavy. Okay? So sa patient natin, she calls for bleeding heavy. So in terms of volume, heavy menstrual bleeding yung label natin kay patient. Now what are the other symptoms under Figo AUB System 1? So the other symptoms are intermenstrual bleeding. So pwede siyang pwedeng random, pwedeng cyclic, meaning may predictable time kung kailan ka nag-intermenstrual bleeding. Kung kailan ka nagsa-spotting, nagbi-bleeding in between your regular menstrual period. Alright? Pwedeng early cycle, mid-cycle, or late cycle. So ito, unscheduled bleeding if the patient is on pills. So, sige, ito na muna tayo guys. Doon tayo sa regularity. Gusto ko siyang balikan. So, ano yung ibig sabihin ng regularity and cycle variation? Okay, so before that, I would just like to mention na wala na kami nitong mga terms na to. Pero I just want you to be familiar with them kasi nasa blueprints pa rin siya. So, possibly matanong pa rin kayo sa boards about it. So, when you say menorrhagia, heavy menstrual bleeding, malakas yung pagdudugo. Hypomenorrhea, it means hindi ka ganon ka, ibig sabihin, kabalikan siya ni menorrhagia, makonte lang yung iyong bleeding. When you see metrorrhagia, your menses are frequent. When you see menometrorrhagia, so meno, malakas, metro, irregular, yung bleeding mo, okay? Or madalas yung bleeding mo. So, oligomenorrhea, we still use this term kapag infrequent ang regla mo. Polymenorrhea pag sobrang dami. We don't use polymenorrhea that much, but oligomenorrhea, we still use that term a lot. So now I want to introduce to you the concept of amenorrhea. What do you mean by amenorrhea, Doctora? It means when you are not bleeding. So for how long? So depende muna siya kung primary or secondary. So primary is never pang nagme-menarche yung patient. So kailan natin siya dinedetermine? Kapag hindi pa nagme-menarche yung patient by the age of 15 in the presence of secondary sexual characteristics. So ang isang marker natin doon is the presence of breast. Okay? So kung may halimbawa may secondary sexual characteristics na siya like pubic hair, and breast, tapos 18 years old na siya, hindi siya nagre-regla, that is a cause of concern for us. So, what is the other definition for your primary amenorrhea? Kapag nagkaroon siya ng breast development before 10 years old, and within 5 years from TELARC, hindi pa rin siya nagme-met. So, that is another cause of concern. We therefore investigate the cause of the primary amenorrhea for that patient. Example, 9 years old ako nagka-breast. By age of 14, hindi pa rin ako nagkakaroon ng men. Then, dapat yung parents ko ay ma-concern at i-consult ako with a gynecologist. Okay? So that is for primary amenorrhea. When you see secondary amenorrhea, it means nagre-regla ka before but it stopped for an arbitrary period of time. And most of the time, we set this at 6 months, at least 6 months. Okay? So, yun yung secondary amenorrhea. Okay, so doon na tayo sa regularity. Bakit? Kasi di ba nakakalito, Doktora, so ano ba yun? Bakit ang normal less than or equal to 9 days tapos may irregular ka na greater than or equal to 10 days? Eh di yung 9 days, Doktora, kasama pa rin siya sa range na normal. Okay, so ganito kasi siya, guys. Depende siya sa age ng patient mo. If your patient is 18 to 25 years old, yung cycle variation mo should be less than or equal to 9 days. Pag 26 to 41 siya, less than or equal to 7 days. Pero those who are 42 years old to 45 years old, less than or equal to 9 days yung variation. Okay, nakakalito, no? So, basically, less than or equal to 9 days talaga ang normal variation, except if you're 26 to 41 years old. So, mas maikli yung allowable cycle variation niya kasi this time dapat regular ka na, less than or equal to 7 days. Okay? So, what do you mean by cycle variation, Doktora? Okay. Yan. So, for example, ito yung day 1 ko. This is my cycle number 1. Cycle number 2, ito yung next day 1 ko. So, bibilangin ko kung ilang days between this to this. Yun yung interval. Alright? Ito yung next cycle ko. Ito yung next LMT ko. Okay? So, ito yung, sabihin natin na, basta ito yung next regla ko. Okay? Ito yung first day nung next kong regla. Ano yung difference ng day 1, this day 1 to this day 1? Sabihin natin 30 days. Okay? Tapos between this day and this day, 35 days. So, ang cycle variation ko, if ito yung shortest ko at ito yung longest ko, ay 5 days. So, since nasa, dito ako sa age range na to, pasok pa ako sa regular. Na-get? For example, same patient, no? 26 years old. Pero yung urong natin ng konti, 40 days yung longest cycle niya, 30 days yung shortest. Okay? So, meron kang 10 days na cycle variation. Okay? Sabihin na natin ganon. Ibig sabihin, considered irregular na siya. Dahil, from 26 to 41, dapat up to 7 days lang yung cycle variation. Nag-get? Okay, so I hope clear yon in terms of regularity because sa FIGO AUB System 1. So yung System 1, sa symptoms pa lang yan. Iba pa yung Symptom 2. System 2. Okay, so balikan natin si patient. So negative pregnancy test. So hindi na siya, wala na siya sa mga early pregnancy complications. Nasa AUB na siya na diagnosis. Na doon na siya na algorithm magpo-fall. Kung titingnan natin, regular naman si patient. Tama naman na regular siya. 3 days lang yung interval. Tapos, ay yung cycle variation. In terms of interval, di ba, ano ba yung normal dapat? So, nasa 24 to 38, pasok naman si patient kasi 28 days siya. However, prolonged siya kasi di ba more than 8 days. So, 10 days. So, prolonged yung bleeding niya and heavy. This is patient-determined, pero kung papansinin mo rin yung report niya, 2 adult diapers, it's definitely heavy in terms of flow. And nasa day 2 natin si patient. Alright? Kasi second day na nilabasan siya ng regla. Okay, so AUB na si patient. Itatag na natin siya sa case of AUB. Now, what is causing her abnormal uterine bleeding? Now, this is another classification of FIGO. So, ito na yung System 2. Yung kanina, symptoms ngayon, sa FIGO System 2, it's your cause naman, di ba? So, ang tawag namin dito is POM coin. So, POM coin, divided siya into 2 groups. The first group is your structural causes. So, ano ibig sabihin ng structural? Ito yung makikita mo on imaging or histopathology na causes of abnormal uterine bleeding. Si non-structural, kung papansin niyo, more of mga comorbid condition siya na makikita mo on laboratory test. Okay? So, dito muna tayo kay structural. So, ano yung mga under-structural? Isa-isahin din natin to later on. These are your POM. Okay? P stands for polyp. A stands for adenomyosis. L is leiomyoma or myoma. M stands for malignancy and hyperplasia. So, huwag kayong magkakamali ha. M does not stand for myoma. That is L, kung myoma, yung cause ng bleeding mo. Leiomyoma siya sa POM coin system natin. Okay. Now we go to AUBP. Okay? So, siya yung first cause under POM, which are your structural causes for abnormal uterine bleeding. So, your polyps, these are localized overgrowth of endometrial tissue containing glands, stroma, and blood vessels covered with epithelium. Actually, ito yung PASO diagnosis natin. Ito yung PASO criteria para matawag na polyp yung makikita sa loob ng matres. Kailangan meron siya nito, glands, stroma, and blood vessels. So your polyps look like this, no? Ito yung graphical representation niya. And most of the time, presents with intermenstrual spotting. So may iba pa siyang patterns of bleeding, pero why intermenstrual spotting? Kasi sporadic yung pag-ano niya, di ba? Hindi mo ma-predict kung kailan siya magbi-bleed. Itong mga maliliit na ito. Okay? Yung polyps natin. So, most of the time, they present with intermenstrual spotting or bleeding in between your regular menstrual cycles. Okay, so anong itsura niya, Doktora, on ultrasound? So this is how it looks like on ultrasound. So they present as thickened endometrium with cystic spaces. So yung mga anechoic areas na yan, yan yung mga polyps natin. Okay, na naka-intersperse within the endometrial cavity. Now, to better delineate yung mga intracavitary lesions, what we do is SIS, saline infusion sonography. So we inject sterile water into the endometrial cavity. So madidistend niya yung endometrial cavity, tapos mas madidelineate namin yung mga polyps, yung mga myomas, ganyan. Basta any intracavitary lesion, the SIS will help us delineate those lesions, no? So mas mapaplan out namin yung surgery namin well. So ayan. So ito yung isang example ng SIS na may mga polyps on scanning. Okay? So ito yung itsura niya, guys, on hysteroscopy. So when you say hysteroscopy, you insert a camera into the endometrial cavity to directly visualize the lesion. So ito siya. Mukha siyang pedunculated lesion. So parang siyang finger-like projections that are smooth. They're very benign looking. Tapos ito yung gross picture ng isang polyp. Okay? So there are smooth projections into the endometrial cavity. So yeah. Mukha lang talaga silang focal na growth ng mga glands within the endometrial cavity. So, anong ginagawa namin sa polyp? Our usual plan for polyps are, if available in your institution, na preempt ko na, it's hysteroscopic polypectomy. So, the next cause under palm coin is your adenomyosis or AUBA. So, another name for adenomyosis is endometriosis interna. Although I don't like to emphasize this term because ibang-iba ang pathophysiology ng endometriosis with your adenomyosis. But just the same, what happens is both of them have aberrant endometrial glands. But in adenomyosis, it's specifically found in your myometrium, okay? Nasa muscle siya ng matres mo. So this causes hypertrophy of the surrounding myometrium. Kaya sobrang sakit nila magregla, guys, okay? Because every time nagre-regla sila, imagine these glands will cause release of prostaglandins from your surrounding myometrium. So masakit na masakit to magregla. And because of that, there will be impaired contractility. Kaya lumalakas din yung bleeding nila, okay? Nag-AUB sila because of that. So, to be more specific, ang patho definition ng adenomyosis is that the endometrial glands and stroma should be more than 1 LPF or 1 low-powered field on microscope or at least 2.5 millimeters from your basalis layer. Okay? So basalis is, ito yung pinaka-loob na layer ng endometrium mo. Diba yung sa labas is functionalis, yung nasa ilalim niya is your basalis. So if your endometrial glands or stroma are found at least 1 LPF or 2.5 millimeters, then you're dealing with a case of adenomyosis. So as I mentioned, they present with dysmenorrhea. Super sakit nito, guys. Ang chief complaint nila sa inyo, Doktora, every month na lang po pag nagkakaroon ako, ang sakit po ng dysmenorrhea ko. And on top of that, malakas po ako magregla. Okay? And another symptom that they could experience is that lumalaki po yung matres ko, parang may nakakapapo ako. Okay, so bakit lumalaki? Note na because of the endometrial glands that are aberrant, nagkakos siya ng hypertrophy of the surrounding myometrium. So posibleng magkaroon ka ng diffusely enlarged uterine corpus. Okay, so ang bago sa FIGO classification system natin noong 2018 is further defined na yung ultrasound findings of adenomyosis. So hindi ko na isa-isahin, but I'd like to emphasize siguro this one, merong asymmetric thickening of your myometrium. So sometimes yung posterior yung makapal, minsan yung anterior. So bakit mas makapal yung isa over the other? It's because of the aberrant glands, okay, that are present in one side of the myometrium. So, possible naman na nasa anterior yung glands mo kung yun yung mas makapal or sa posterior. Okay? Tapos meron din siyang ganitong appearance, no? When I was a resident, we call this Venetian blinds, okay? Kaya sa Venetian blinds kasi yung tama ng echoes mo, i-disperse siya nung mga aberrant na glands that are found within your myometrium. Such that, ganito yung itsura niya on ultrasound, okay? So para kang may blinds, may fan-shaped shadowing ka, acoustic shadowing. And if you notice, the posterior myometrium is markedly larger than your anterior myometrium. So most likely, the aberrant glands and stroma are found here in this part of your uterus. Okay, so on gross specimen, ganito yung itsura niya. Supposedly, ang matres mo, maliit lang yun ganito. Tapos, very regular yung itsura niya. But ito, as you can see, mas makapal na makapal itong anterior over the posterior myometrium. So, ganyan. Ganyan yung itsura ng mga matres with adenomyosis if itatabso sila or total hysterectomy. Okay. So this is a very common structural defect, your leiomyoma. So it is a benign tumor of smooth muscle origin, and ang kanyang common AUB presentation is heavy menstrual bleeding with enlarged corpus. Sometimes, mapifeel mo to on your by manual examination, irregular yung contour. Kasi basically, yung myoma mo, kahit saan yan pwedeng mag-grow. Pwede nga yan mag-grow sa ligaments So anyway, yung leiomyoma, they present with heavy menstrual bleeding because they distort the endometrial cavity. So those are just one of the ways, marami kasing mechanism behind AUB caused by leiomyoma, pero one of which is distorting your endometrial cavity. So kapag na-distort mo kasi siya, it will cause increase in the surface area. So one more thing that allows leiomyoma to cause abnormal uterine bleeding is magkakaroon ng impaired contractility yung matres mo. So kahit hindi ka buntis, may contractile factor pa rin yan, guys. Kasi yun yung primary mechanism ng matres mo to regulate the bleeding, no? It vasoconstricts and contracts to prevent heavy bleeding. So kapag meron kang mga smooth muscles na ganito, na leiomyoma, these tumors prevent the normal myometrium from contracting properly. Thus, they present with heavy bleeding. So, kung papansin niyo, meron kaming iba-ibang kinds ng myoma depending on its location in your uterus. So, submucosa is right beneath your endometrium, no? So, ito yung pinaka-nakaka-cause ng bleeding. So, yung pinaka-notorious. So, your other kinds of myomas are intramural. Meron din tayong subserosal. So, right beneath the serosa. Ayan. So, yun naman yung mga basics. So, later on, ititingnan natin yung FIGO classification kasi pina-classify din namin siya based on location sa FIGO. Okay. So, ang itsura ng mga myomas, guys, ay hypoechoic area. Okay? Remember, hyperechoic kapag puti. Hypoechoic kapag mas dark siya than your other echoes. Okay? So, ito, hypoechoic siya. So, kitang-kita mo siya, it's well delineated. Ito ay actual patient na may hypoechoic na well-defined area, well-defined mass sa myometrium. So yan, yan yung mga sample pictures ng leiomyoma. Okay? Grossly, ganito siya. No? Makikita mo meron siyang whorled pattern. Okay? Yun yung classic description sa kanya. So pearly white, na solid, well-defined, na may whorled. As in W-H-O-R-L-E-D. Wala ko ba't nabubulol ako today? Basta yun, whorled appearance. Okay? Uncut section. Ayan. So, guess nyo guys, kung bakit minsan irregular yung contour ng ng uterus mo when you palpate them on by manual exam. Kasi tingnan mo to, kung saan-saan yung mga knobby structures mapapalpate because of the different locations of your myoma. Okay? Okay, so ang FIGO, mas papahirapan pa niya tayo. Pero yun nga, sabi ko kasi sa inyo, sobrang dami ng may myoma. So we really have to define well yung classification natin for it, such that we have a sub-classification system. So this is our sub-classification for leiomyoma. So when you have a submucous myoma, bukod sa L, nilalagyan din namin yan ng SM. Okay? So L tapos subscript SM. Kapag hindi naman submucous yung myoma mo, you will put O. Okay? Others. O is for others. Yan. So may special classification system pa si leiomyoma. So, meron kaming tinatawag na FIGO grade 0, type 0 to 8 in terms of leiomyoma. So, para madali nyo siyang maalala, guys, tandaan nyo lang si 0, saka si 7, saka si 4. Okay? Pag sinabi mo kasing 0, it means that it's pedunculated intracavitary. Nasa loob siya ng matres. Si 4, it's the one that is completely intramural. Si 7, kabaliktaran ni 0. So siya naman ay pedunculated na sub-zero. So nasa labas siya ng myoma. So the rest, i-imaginein mo na lang parang ginagalaw mo yung myoma within the myometrium. So C1 is mostly submucosal pa rin, but with intramural component na less than 50%. So pag pinasok mo siya ng konti, more than 50% na intramural component, pero may submucosal component pa rin. So urong mo siya ng konti pa, magiging siyang C3. So intramural siya, most of it, but meron siyang contact sa endometrium. So sa bagong classification system, C3 is considered as a mucous myoma pa rin because yung pattern of bleeding niya will still be the same as that of your 1 or 2. Okay? So ito, C3, kahit mostly intramural siya dahil it still contacts your submucosal area, it's considered a submucosal myoma. Okay? Na-get? So again, C4, siya yung completely intramural. So kaya siya yung tinatandaan ko kasi sa kanya ko binibasis yung pag-usog loob or palabas nung classification ng myoma. When you say 5, it's still more than 50% intramural but with sub-serous component already. When you that's for 5. When you say 6, urong mo ng konti. So less than 50% na yung intramural niya and mostly sub-serous na siya. And then finally, si 7, sub-serous pedunculated. Si 8 is for others. Meaning, kapag mayroon kang mga cervical myoma like this one, or parasitic myoma, or meron ka sa mga ligaments mo, yon. Pwede namin yung i-designate as 8. FIGO 8. So, ano yung mga hybrid? Pag sinabi mong hybrid, parang ganito. So, para siyang si 2, such that more than 50%, meron siyang, kung hahatiin mo yung myoma, more than 50% ay intramural pa rin with submucosal component, but at the same time, sa sobrang laki ng myoma mo, it traverses the other side of your myometrium such that meron kang sub-serous component. So 2-5 yan, yung i-denote namin dun sa iyong myoma. Okay, so the next, this is the last na cause of structural abnormal uterine bleeding is your endometrial, your AUBM. Endometrial cancer or malignancy or hyperplasia. So kasama si hyperplasia with or without atypia sa AUBM. So ang primary cause ng AUBM is your unopposed estrogen. Okay? So because of your unopposed estrogen, andun lang siya sa proliferative phase. Remember yung menstrual cycle natin, no? So magtitikin lang siya ng magtitikin. So ano ang presentation or pattern of bleeding niya? They usually present with prolonged menses and heavy menses. Bakit? Kasi hindi na siya cyclic, no? Dapat every month, di ba, isi-shed mo yan. Pero what happens in cases of thickened endometrium like this, kapal lang siya ng kapal until ma-overcome na niya yung blood supply. So saka lang siya mag-bleed. So imagine, sobrang kapal na niya since hindi siya nag-bleed prior, hindi siya nag-shed prior. So once nag-bleed yung mga patients with AUBM, they present with prolonged, sobrang haba, and heavy bleeding, sobrang lakas na bleeding. On ultrasound, you see thickened endometrium Okay? So, in cases of malignancy, sometimes you see that the the endometrium is already invading into the myometrium. Okay? So, hindi na clear yung endomyometrial junction. So, that's in cases of malignancy. However, meron din namang mga endometrial cancer na hindi pa nakakalampas ng endomyometrial junction. So, paano mo ma-differentiate yung dalawa? You do a biopsy. Okay? So, endometrial biopsy will distinguish between endometrial malignancy and hyperplasia because they could present very similarly on imaging. Okay? Ayan. So, let's go back to our index patient. So, si 26-year-old naligavid patient, she presented with heavy, I forgot to mention here, prolonged din, di ba? Kasi 10 days. So, heavy and prolonged menstrual bleeding with dizziness. So, most likely, this is acute kasi kailangan nating mag-intervene for this patient. So, you ordered these these labs for your patient. That's CBC and blood typing. On CBC, you found her to have anemia, okay? So, you hydrated the patient, you gave IV tranexamic acid to lessen the bleeding. So after that, you will now perform your speculum and your bimanual examination. So now let's watch this video on speculum and bimanual examination by Doc Chris. So kunwari normal yung findings mo kay patient ha. So paano ba yon? So ganito ko usually ganito namin nire-report yung normal findings on bimanual examination. So we start from outside going in. So we say normal external genitalia, smooth vagina, cervix 3 by 3 centimeters, smooth, corpus small, no adnexal mass or tenderness. Okay, so na-imagine nyo, so sa gitna, kakapay muna namin yung corpus sa gitna, and then we go to each side for the adnexa. So, ang normal finding is no adnexal mass or tenderness. And then we perform rectovaginal examination. When you say rectovaginal examination, isang daliri sa puweta, isang daliri sa puwet. Okay, so ipapaalam siya sa patient. So, we start by reporting good sphincter tone, intact rectal valve, no intraluminal masses, and then no nodularities in the cul-de-sac. So I mentioned this because sa REI, we frequently have patients with endometriosis and they present with nodularities here in the cul-de-sac, no? So cul-de-sac, ano ibig sabihin ng cul-de-sac? Ito, mas kita dito yung cul-de-sac. Cul-de-sac is your rectouterine pouch. Cul-de-sac literally means blind pouch, okay? So ito siya, blind pouch siya. So that's your cul-de-sac. So ito yung kinakapa namin on rectovaginal examination. And we also palpate for the bilateral parametria. So pag normal, we say smooth and pliable. So ano ba yung parametria? Parametria, it is this area of your broads, no? This side your cervix. Yan. So yan yung parametria mo. Yan yung kinakapa mo. Kailan po ba siya, doktora, nagiging abnormal? Pag meron kang cervical cancer, you would usually palpate na bulky itong parametria mo. So, hindi mo siya ma-report as smooth and pliable. Pliable meaning ma-close, ma-oppose mo pa yung fingers mo on rectovaginal examination. Okay? So, yan. Ito yung parametria na kinakapa namin on rectovaginal examination. So, ito ang normal findings. But what did we find in our patient? So, one other concept that I'd like to mention is the concept of anteversion versus retroversion and retroflex versus anteflex. So, when you say version, sige, balikan natin to. When you say version, it's the direction of your uterus in terms of the axis of the vagina. So, pag sinabi mo na anteverted, it means that the corpus is more towards the symphysis pubis and retroverted siya if more towards the sacrum. Okay? So, in reference siya to the vaginal axis. So, again, anteverted, retroflex. Anteverted and retroverted. Okay? Pag sinabi mo namang anteflex or retroflex, depende naman siya kay fundus. Okay? Pag si fundus mas nakabow towards the symphysis pubis, then it's anteflex. Okay? Fundus siya. Flex. Okay? S. Pag more towards the sacrum, retroflex. Okay? So, kaya yan yung mnemonic ko. So, sa version, in terms ng axis ng vagina, yung uterus in relation to the axis of the vagina, and flexion, yung fundus naman, yung marker mo for seeing if it's anteflex or retroflex. Okay? So, again, these are the normal findings. So, ano naman yung na-find natin sa patient? Okay. On bimanual examination and speculum examination, this is what we saw. No? You saw a 4 by 3 centimeter smooth fleshy mass prolapsing out of the cervical canal. So, ito yung graphical representation natin dyan. Meron siya dyang nakakapang mass. And the corpus was enlarged to 14-week size. So, di ba, remember your umbilicus, that's 20-week size. Between the umbilicus and your symphysis pubis is 16 weeks. So, a little under 16 weeks yung kapa mo sa matres niya. And ultrasound shows a hypoechoic solid mass. Okay? Dilating the endocervical canal, which is this one, no? Ito yung cervix. Ito yung nakakapamang 4 by 3 centimeters smooth fleshy mass. Okay, so siguro alam niyo na kung anong diagnosis nitong patient na to. So itong patient is a case of AUBL1. So ito yung expanded notation, no? So kunwari na-rule out na natin yung iba, pati yung mga medical or yung mga non-structural causes. So ganito talaga yung expanded notation niya. So since leiomyoma siya, AUBL1, pag halimbawa yung hindi absent yung mga other causes, we denote it with 0. Okay? Pero since leiomyoma siya, we write 1 and then open close parenthesis SM kasi submucous siya. Prolapse, in fact, prolapse submucous myoma sa patient natin. Now, the shorter or the abridged version of that diagnosis is this one. AUB, so tanggalin mo na itong mga other causes of AUB. So, L na lang yung ititira mo, subscript SM. Okay? So, what if intramural pala yung myoma ng patient mo, but it distorts the cavity kaya nag-AUB? Ganyan. So, instead of SM, you put O. Okay? So, paano kung both naman siya? Meron siyang submucous, meron din po siyang intramural na myoma. And then, we write L subscript SMO. Okay? So, Doctora, what if on top of leiomyoma, meron pa siyang ibang pathology? Like, say, for example, adenomyosis. And then, we add A. Okay? So, yung full diagnosis niya in terms of the abridged or shorter version is AUB-AL plus the subscript, no, SMO, kung depende sa anong kinds of myoma that are present in the patient. Okay, so further, sometimes we further, tawag nito. Okay, so doon sa mga nagpa-plan ng surgery for the patient, it will be more helpful if you put kung anong FIGO grade niya. So dahil sinulat niya na FIGO grade 1, yung patient, or FIGO 1, yung myoma niya, yung submucous myoma, then mas nai-imagine ko kung anong itsura niya. It means it's mostly submucosal, but there is a less than 50% na intramural component. Okay? Ayan. So my plan for this patient, because she is young, 26-year-old, and she's still naligravid, my plan is to perform hysteroscopic myomectomy. Okay? So your plan will change depending on the age of the patient, the desire for future pregnancy, etc. So mag-iiba yung plan. For example, ito, nag-iba yung plan ko kasi itong patient na to, she's 48 years old, G7, P7. Sabihin na natin na postmenopausal na tong patient na to or perimenopausal na. So you already decide to remove the entire uterus altogether, together with the fallopian tube. Mamaya sasabihin ko kung bakit sinasama na namin yung fallopian tube. Hindi na kami TAH lang, total abdominal hysterectomy. Now we include the bilateral fallopian tubes when we perform total abdominal hysterectomy. So ayan. So nag-iba yung plan ko. No? Kasi nga, sabi ko nga, depende siya sa age ng patient and sa desire for future fertility. All right. Okay, let's go to the next case. So we have a 12-year-old who presented at the ER with pallor and dizziness. So her mother reported that she had her first menses 4 days prior. On PE, there was note of profuse vaginal bleeding with passage of blood clots and bruises in her extremity. So may easy visibility to see patient. She was given oral tranexamic acid 2 days prior when she consulted at the OPD. What is the most likely cause of abnormal bleeding in this case? So tingnan muna natin yung case, no? So yung age ng patient, she's a young patient na nag-menarche, kaka-menarche pala. And on top of that, meron siyang signs ng coagulopathy, no? Meron siyang easy visibility. So most likely, this is a case of coagulopathy, okay? AUBC. Now we'll look at the non-structural. Non-structural part naman tayo ng palm coil. So yung non-structural, ibig sabihin na to, diba? Kung structural is makikita mo sa imaging and sa histopathology, itong non-structural naman is more of sa mga laboratory findings and history ng patient. So the first is coagulopathy. So ito na yung index case natin, no? Coagulopathy. So most of the time, yung mga patients with blood dyscrasia, pagka menarche nila, minsan dun lang nila nare-realize na meron pala silang problems in coagulopathy, no? So ano yung mga other examples ng AUBC? So yung mga AUBC, pwedeng yung mga may von Willebrand disease, may hemophilia, yan. So basta meron kang inherent problem with your coagulopathy, then pasok ka sa AUBC if you present with abnormal patterns of bleeding. Doktora, paano po yung mga sabihin natin naka-warfarin, doktora? Kasi di ba parang may ano din yun, ma-change din yung coagulopathy mo. Hindi na siya part ng AUBC. That will be AUBI, okay? Basta gamot yung nagpo-cause ng change in ng coagulopathy problems, then hindi na siya AUBC. That will be considered under AUBI, okay? That is one of the clarifications sa latest na FIGO 2018 revision, okay? So yung mga warfarin, vitamin K, antagonist, ganyan, so aspirin, pag nabigyan yung patient nun at nag-bleed siya, AUBI na siya, hindi siya AUBC. Sa AUBC, dapat inherent problem talaga siya sa coagulopathy, okay? So, next is AUBO. So, ano yung mga AUBO? Basically, yung AUBO, palikan nyo lang yung HPO axis. So, anything that causes problems along your HPO axis will cause AUBO. Ang pinakasikat dito is si PCOS, no? So, mami, i-discuss ko extensively the pathophysiology behind PCOS or polycystic ovarian syndrome. Hypothyroidism, hyperprolactinemia, mental stress, extreme exercise. Basically, these are conditions that inhibit your GnRH. So dahil mababa or inhibited yung GnRH mo, then lahat ng hormones down the cascade from your pituitary glands to your gonadal hormones ay mababa na rin. Okay? So yan yung ito lang yung mga some examples under AUB. Okay. So next under your structural cause is your AUBE or endometrial cause, okay? So, si AUBE, guys, rarely namin to ma-diagnose because si AUBE means na meron kang disproportionately more PGE or prostaglandin E than your prostaglandin F2 alpha. So, bakit hindi natin to gusto? Si prostaglandin F2 alpha, guys, this is for your vasoconstriction and contractility ng uterus. So, dahil sa kanya, nagdi-decrease yung bleeding, okay? Obviously, kasi nagbabasoconstrict, tapos nagko-contract. Si PGE naman is kabaliktaran, no? Siya yung prostaglandin responsible for vasodilation. So, anong mnemonic natin for this? Ang gusto natin si S, siya yung friend natin. Si E is yung ating enemy, okay? Kaya siya E. Unfortunately, siya yung mas mataas in cases of AUBE. Okay? So, as you can see, medyo mahirap siyang i-diagnose, no? Yung AUBE kasi hindi naman, wala nang talaga tayong assay to say na mas marami yung PGF2 alpha over PGE or vice versa. Next is your iatrogenic. So iatrogenic is when the patient was, for example, given hormones like estrogen, progestin, or for example, medications that alter your coagulopathy like your warfarin, your vitamin K antagonist. So pag nabigyan sila nun and they present with abnormal patterns of bleeding, then we label them as AUBI. CN finally is not otherwise classified. Before, ang pangalan nito is not yet classified. Pero sa newest PIGO division, not otherwise classified na siya. So ano yung mga under ni not otherwise classified? Examples are AV malformation. And may isa sa lang example nun, ismosil or abnormalities or breaks in your previous cesarean section scar. Pwede daw yun makakos ng abnormal uterine bleeding. So those things, hindi pa sila naka-classify under either POM or any of this COA. Yan, so wala pa sila doon. So nasa N sila. So AUBN. Alright. Sige. Let's go to our next index case. So we have a 31-year-old nulligravid. She's irregularly menstruating every 70 to 90 days. No? So hindi ko na kailangan i-compute. Obviously, matagal tong interval na to for a patient in her reproductive age group. Prolonged and heavy bleeding. No? So minsan na nga lang siya magregla every 70 to 9 days. So this around every month to 3 months. Tapos prolonged pa and heavy yung kanyang pattern of bleeding for 5 days. Now, she also noted weight gain, no? So, BMI 27. Sabihin na natin, BMI 23 siya before. So, she noted weight gain and acne. And also, she's hirsute, no? Marami siyang hair in her parts of the body like chest, sa kanyang back, sa kanyang upper lip, and sa legs. Okay, yun yung na-note mo sa patient. And her LMP is last October 2021 pa. So, very good ka naman. You performed a pregnancy test. Turned out to be negative, no? Kasi matagal na amenorrheic si patient. 3 months siyang di nagregla since you last saw her. So, ano ang consideration mo for this case? So, you have a patient na irregularly bleeding, tapos meron siyang hyperandrogenic symptoms, no? Meron siyang signs of hyperandrogenism. Diba? So, hirsutism, acne, and weight gain. Ayan. So, this is most likely a case of PCOS or polycystic ovarian syndrome. So, nung pina-ultrasound mo siya, true enough, ito yung morphology ng kanyang ovaries. You see that there are multiple follicles, more than 12 siguro to na follicles, na less than 10 millimeters na peripherally located, no? So, ganyan yung morphology niya on ultrasound. So, this patient, pasok na pasok siya sa AUBO secondary to PCOS or polycystic ovarian syndrome. So, bakit siya lights, camera, action? Yan. So, bakit siya pasok sa PCOS? So, pasok siya because she was able to fulfill 2 out of 3 of the required criteria in your Rotterdam criteria for PCOS. So, pasok siya dito, di ba? Oligo or anovulation. Meron siyang clinical signs of hyperandrogenism such as your hirsutism and your acne, weight gain. And on ultrasound, yung ovaries niya look polycystic, no? There are more than 12 follicles, greater than or equal to 12 follicles na less than 10 millimeters ang diameter on each ovary. Okay? Ayan. So, pasok siya sa Rotterdam criteria. Okay, so what is the pathophysiology behind your PCOS? So, it all starts with your GnRH pulse na increase, okay? So, because of the increased GnRH pulse, what happens is there is a disproportionately higher LH compared to your FSH. So, si FSH mo dito, most of the time, normal yan, no? Pero kung i-compare mo siya sa LH, si LH would be 3 times higher than your FSH. So, remember, di ba guys, the LH, this is responsible for your steroid hormone production, so for your androgen production. So what happens is, it stimulates the theca cells of your ovaries to produce a large amount of androgen. So dito nang gagaling yung hyperandrogenism ng patients with PCOS. So on top of that, si FSH, anong nangyayari kay FSH? Yung amount niya is enough to cause maturation of your follicles, pero nag-a-arrest, okay? Nag-a-arrest yung mga follicles mo at a certain point in their development. So ang nagiging itsura niya, on ultrasound, ang morphology is, meron kang polycystic ovary, then let's say FSH. FSH action. So, si FSH naman, normal naman siya. So, nakakapag-recruit siya ng follicles monthly. However, dahil hindi enough yung levels ni FSH mo, nag-a-arrest yung maturation ng mga follicles na yun. So, wala kang napoproduce na dominant follicle. So, ang itsura ng ovaries na may polycystic ovarian syndrome is because of the decrease in FSH or the marked decrease in FSH compared to your LH, meron kang polycystic looking morphology, no? Nagiging cyst lang siya, pero wala ni isa sa kanilang nagiging dominant follicle na nag-ovulate, okay? Walang lumalabas na egg, kumbaga. So, dun nangyagaling yung anovulation ng patient. On top of that, because of your increased androgen production, tumataas din ang estrogen production mo. So when you have increased estrogen production, this inhibits your gonadotropin, no? So dun isa pa yung mechanism of action as to why may anovulation yung patient with PCOS. So another facet of your PCOS pathophysiology is that they have insulin resistance. So your obesity, your dyslipidemia, they both contribute to the insulin resistance in these patients. So because of the insulin resistance, so resistant yung katawan mo to insulin. So nangyayari ay nagpo-produce ka ng mas marami pang insulin. Okay? Nagkakaroon ka ng hyperinsulinemia. Because hindi nag-respond yung body mo to the insulin. So inisip niya, so I have to produce more insulin. So because of the hyperinsulinemia, mas na-stimulate pa niya yung theca cells to be more responsive to your LH. So, ito na yung cycle na yun, okay? So, mas nagiging hyperandrogenic yung patient, and your androgens, in the way, contribute to the insulin resistance. So, nagiging siyang cycle. So, that is the pathophysiology behind your PCOS. So, ano ang treatment namin? The first-line treatment is still diet and lifestyle modification. So, we advise our patients to exercise at least 150 hours a week, and then eat low salt diet. Ayan. So yung mga inaano namin sa kanila, ina-advise namin sa kanila. For the AUB, we give oral contraceptive pills. And then for the infertility part, because most of these patients, dahil nga anovulatory sila, hindi sila nagproduce ng egg, we have to induce their ovulation, no? So we give either clomiphene citrate or letrozole. So yan, ganito namin i-manage yung patients with PCOS. Okay. So, I just want to go back dun sa part kung bakit nag-AUB yung patient natin with PCOS. So, remember, puro estrogen si patient. Wala siya na-produce na dominant follicle that will eventually ovulate. So, dahil dyan, kumakapal lang ng kumakapal itong lining ng matres niya, no? So, it stays in the proliferative phase. So, kakapal lang yan ng kakapal. Ayan. So, kakapal siya ng kakapal until ma-overcome na niya yung blood supply. And that's when they bleed. Okay? Kaya bihira silang mag-mens because hindi sila nag-ovulate. So, walang point in their cycle na nasa slough off nung kumakapal na lining na to. But when they do bleed, heavy naman yung pattern ng bleeding nila. It's because ang tagal ng kumakapal ng matres, ngayon pa lang sila magbi-bleed. Okay? Bakit ngayon pa lang magbi-bleed? Kasi ngayon pa lang nila na-overcome yung blood supply ng myometrium. Okay? Ng endometrium rather. So, kaya lang sila nag-bleed dahil lang doon. No? Nag-hypoxia na yung mga itong endometrial glands and stroma sa taas. Okay? So, sobrang kapal na niya. Kaya ganun yung pattern ng bleeding ng ating patients with PCOS. So I hope that's clear. Yan. We move on to the next chief complaint. So tapos na tayo sa abnormal uterine bleeding, we move on to vulvar lesion. So for this, magbibigay ulit ako ng mga index cases. Okay, so before that, review muna tayo ng external genitalia anatomy. So this is your mons pubis. This is your labia majora, labia minora. This is your clitoris. Prepuce is the hood, no? Yung parang siya yung skin overlying your clitoris. Below your clitoris will be your urethral meatus or the opening into the urethra. This is your vagina. This is the furcet. So pag nag-episiotomy kami, we start with the furcet, no? Whether we do it via RMLE or right mediolateral episiotomy or ME or median episiotomy. Okay? So this is the perineal body. When you see vestibule, it is this part, no? Kasama yung urethral meatus. Ito yung part na to, vestibule yan. So this is the adult form, kumbaga, of your urogenital sinus. Okay? So an important note is that itong labia majora and labia minora, ito yung mga homologs nila. Scrotum for your labia majora. For your labia minora, it's the ventral portion of the penis. Tapos, magkaiba sila ng lining, no? Non-keratinizing itong labia minora. In other words, itong super pink na area, no? Itong labia minora, non-keratinizing yan. Yung labia majora, yung outer niya is keratinizing. So, pag keratinizing, meron kang keratin layer, so that is impervious to water. No? So, hindi siya ganun ka-absorbent sa water. Hindi siya parang pink like this ng labia minora. Tapos, ang difference pa na major ng labia minora and labia minora is that si labia majora, meron siyang lahat. Meron siya ng hair follicles, meron siyang sweat glands, sebaceous glands. Si minora, sebaceous glands lang ang meron. Okay? Question, ang vagina ba merong glands? Wala. No? So basically, yung lubrication inside the vagina, that's coming from the exudates, from the rich vasculature of your vagina. Pero wala talagang inherent glands yung vagina ng females. Okay? So that's just a side note. So dito muna tayo sa external genitalia since we're discussing vulvar lesion. So the first case of vulvar lesion is this patient. You have a 15-year-old nulligravid patient who presented for a left-sided labial mass. So ito yung labia mo, di ba? So yung labial mass niya, ang na-encompass niya is the labia minora plus part of the labia majora. So 1 week prior, she noted a pea-sized mass in the 5 o'clock position, which gradually enlarged to a 5 by 6 centimeter mass, which was fluctuant and tender on palpation. So what is the appropriate management? So first, anong diagnosis niyo sa case niya? Dito sa, nagsimula daw siya dito sa 5 o'clock, tapos naging ganito kalaki after 1 week. And this was tender on on palpation and was fluctuant. Okay? So this is a case of Bartholin's gland abscess. So sa Bartholin's gland, ito siya, nandito siya sa 5 o'clock or 8 o'clock. Sometimes, 5 o'clock or 7 o'clock. Or sometimes it's being described as 4 o'clock, 8 o'clock. It doesn't matter. Basta alam nyo na dito sa area na to, dito makikita si Bartholin's gland. And supposedly, ideally, in a normal patient, hindi mo siya mapapalpate at all, okay? Sometimes, what happens is, nakikita nyo to, no, there are small ducts into the vestibule in going into your Bartholin's gland. So when these when these small ducts get infected or obstructed, it causes Bartholin's gland cyst and eventually Bartholin's gland abscess, no? So nagiging nana na yun sa loob. Alright? So kapag nakapamo yan, yun yung abnormal. So I have a side note, I have a side question for you guys. Anong purpose muna ni Bartholin's gland? Mainly for lubrication. So ang homolog ni Bartholin's gland is your Cowper's gland sa males, si Skin's gland. Saan dito si Skin's gland? Si Skin's gland, diba? Ang other name niya is paraurethral. So dapat din hindi mo yan makakapa. Pero dito, around this area, dito mo makikita si Skin's gland. And ang kanyang homolog sa males is the prostate gland. Okay? So si Bartholin, si Cowper's gland, si Skin's gland, si prostate gland. Okay? So now, let's go to the management of your Bartholin's gland abscess. So for her case, since this is already a case of abscess, we do marsupialization. So what is marsupialization? When you say marsupialization, we intentionally create a fistula between the Bartholin's gland and your surrounding epithelium. Okay? So itong epithelium ng labia minora, sinusuture namin sa kanya yung wall ng gland. Okay? Para continuously mag-drain out yung abscess. So when do we perform excision? Okay? So hindi lahat may marsupialization namin. Yung iba, ine-excise. Talagang tinatanggal namin yung gland, no? We perform that in cases of persistent yeast infection, multiple recurrences of abscess, or recurrent enlargement of the gland in women older than 40 years old. At the very least, if the patient presents to you with Bartholin's gland abscess, and she's more than 40 years old, you have to perform a biopsy just to rule out or just to exclude adenocarcinoma. Okay, this is a rare cancer of your vulva, but just the same, you have to do that if the patient is in the elderly stage or elderly age of more than 40 years old. Okay. Ayan. Okay, let's move on to the next case of vulvar ulcer. We have a 17-year-old promiscuous patient who came in with multiple lesions in her anogenital region. So, ito yung itsura ng kanyang lesion, no? So, mukhang papillary projection sa skin. Yan. So, ito yung anogenital region, no? So, ito yung vagina ng patient, ito yung anus. So, dito yung mga papillary projection. Sometimes, it may look like this, no? Hindi lang siya papillary, spiky, lesion. Mukha na siyang cauliflower, no? We describe it as cauliflower-like lesion. So what is your diagnosis of her case? This is a case of condyloma acuminata or your genital warts. So these warts are caused by your human papilloma virus, which are primarily transmitted through sexual contact. Okay? So 90% of your warts are caused by these types, no? HPV type 6 and 11. Kaya ito rin yung mga type na covered by your quadrivalent vaccine, no? 6 and 11. So question, kung ito ay low risk type ng HPV, meaning warts lang yung kanyang makukos, ano naman yung dalawang notorious na types for high-risk types, no? Sila yung nakakakos ng cervical cancer. So these are your 16 and 18, okay? Kaya yung quadrivalent nyo na vaccination, it contains vaccines against 6, 11, 16, and 18. So may protection ka against cervical cancer, and in addition to that, i-address din niya yung mga common HPV types, which are 6 and 11, para ma-protect ka against genital warts, alright? So they present as raised papillomatous or spiked surface lesions like I showed you a while ago, or in worst cases, pwede silang cauliflower-like growth. Okay, so balikan ulit natin yung picture. So ayan, papillary projections, or pwedeng ganito na siya, no, pag mas malala na. Yan, so yun yung genital warts mo. Now, there are different ways to address your genital warts. You could have it via patient-administered treatment or provider-administered. So yung mga provider-administered, pero pwedeng local excision, pwede ka rin mag-cauterize ng warts, pwedeng through cryotherapy, or yung mas common namin ginagawa sa OPD, which is application of this one, TCA, trichloroacetic acid. Okay? We move on to the next case of vulvar ulcer. Sige. So yung kanina is vulvar lesions, ito ulcers naman. Sorry, ibang chief complaint naman na to, vulvar ulcers. So again, I'll go to an index case. Okay, we have a 21-year-old G4 P4 4004. She came in with a chief complaint of this, multiple painful vesicles in her labia majora. Note, painful siya. Okay, that's a very important symptom for this patient. 2 days prior, she experienced malaise and fever, which was followed by burning and pruritus in her vulvar area. So parang siyang may prodrome prior to the appearance of these painful vesicles. So upon inspection, you noted these, no? Multiple vesicles and ulcerative lesions that were painful. What is her treatment? So before you answer me with what is the treatment, ano muna ang diagnosis mo? So most likely, your lesions look like this, no? Multiple vesicles. Sometimes nagpumuputok na siya, so nagko-coalesce yan together, forming the ulcers. And these are painful according to the patient. So this is a case of what? Okay, so when you're presented with vulvar lesions or any vulvar concern for the patient, usually I think of them either as drips or sores. Drips kung discharge, sores is ulcers. Okay, and under ulcers, isipin ko muna kung painful or painless yung ulcer. Si patient, she presented with painful ulcer. So dalawa lang yan. Either it's herpes or chancroid. So mamaya papakita ko sa inyo kung ano-ano tong mga different ulcers na to. I-discuss ko sila isa-isa. So based on her symptoms and based on the appearance of her lesion, this is most likely a case of genital herpes. Yan. So genital herpes, this is a lifelong viral infection. So unfortunately, when you have a patient with herpes, you tell her na lifelong tong infection na to, this could recur in the future. There are two types of HSV, 1 and 2. Si 2 typically yung nasa genital area, si 1 is yung mga nasa oral area. But now, because of the sexual practices of people, pwede na rin may HSV 1 for genital herpes. Okay? Alright. So, ano ang presentation ng genital herpes? So, gaya ni patient, meron siyang flu-like symptoms. And then eventually, may prodrome in the area where the lesions will appear. So, it will feel na may burning sensation, tas may pruritus sa area na yun. And eventually, they will present with vesicles in that area. Okay? So, these vesicles, they will coalesce, they will erupt, causing the painful genital ulcers in your genital herpes. No, so ang pangit dito, yun nga, this virus travels to the dorsal root ganglion of the nerve, which can later on reactivate, causing the recurrences, okay, in the future. So ganito guys, kapag nakakita kayo ng genital herpes na active lesion, or kahit prodrome lang yan, tapos may prior history yung patient na nag-herpes na daw siya, ganyan. Prodrome lang yung burning pa lang, makate pa lang, automatic hindi ka pwedeng mag-normal delivery, okay, sa mga buntis. So pag HSV, active na genital herpes, you have to perform cesarean section for those cases, okay? And as mentioned by the book, this is in blueprints, recurrences are more frequent with your HSV2 infection. So herpes, clinical yan, yung diagnosis mo dyan. But if you really want to verify your diagnosis, you may do the following, no? So kung may isa ka ditong gagawin, ang gawin mo na is this one, your nucleic acid amplification test. Siya yung pinaka makakapag-clinch ng diagnosis mo for genital herpes. So what's your treatment? Of course, because this is a viral infection, you give an antiviral. So these are your options for antiviral treatment for herpes: acyclovir, famciclovir, and valacyclovir. So for the doses of this one, pwede nyo makita sa CDC, okay? Yung complete. Basta for me, enough na sa level nyo, alam nyo kung paano mag-diagnose ng herpes, what causes herpes, how it presents, and kung paano i-treat, okay? At least you have an idea on how to treat herpes. So this is how you treat herpes. You can give acyclovir, famciclovir, or valacyclovir, which are antivirals. Okay, so this is a case of genital herpes. So the answer here is letter A, acyclovir. Okay? We move on to the next kind of ulcer, which is chancroid. So this is the other painful ulcer. So si chancroid, okay? Kaya siya masakit kasi chancroid. Well, kaya siya chancroid kasi masakit. Okay, so it presents as painful and tender ulcer with tender suppurative inguinal adenopathy, lymphadenopathies, or bubo. Okay? This is caused by your Haemophilus ducreyi. So, ducreyi. Okay? So, si chancri, ducreyi. So, everything about this disease entity nakakaiyak. So, it's a highly contagious small gram-negative rod. So, on microscopy, it appears like a school of fish, no? So, meron siyang, ang description dito, soft chancre, soft irregular border, okay? And then, on microscopy, ang pertinent kay chancroid is that you will see this characteristic pattern, no? School of fish appearance. Kasi ito yung mga gram-negative rods na ganito yung configuration nila on microscopy. So, para silang school of fish, okay? Sometimes they refer to this as railroad tracks, yan. So, ito sila. Para silang nakalinya na gram-negative rods. Yan. So, para mas maalala nyo, pag chancroid, di ba? Chancroid is chancroid caused by Haemophilus ducreyi because it's painful. And finally, what you will see on microscopy is a school of crying fish. Okay? So, lahat na lang para lang matandaan nyo yan, guys. So, siguro naman maalala nyo na very painful ulcer ang chancroid. Okay? Ayan. So, ano yung treatment? So, these are your treatment options: azithromycin, ceftriaxone, ciprofloxacin, and erythromycin for chancroid. Now, we move on to the next case of your vulvar ulcer. We have a 26-year-old G6P6 who came in with a painless. So note that, painless solitary ulcer with raised edges on her right labia minora. Okay, kaya kung nireview kayo kanina ng external genitalia anatomy, so she noted that on routine prenatal laboratory exam 6 months ago, her RPR was noted to be reactive. So which is true regarding her case. Okay, so ito na yung clue mo. May laboratory ka and you have a painless ulcer. Okay, so which is true regarding her case. First, what is your diagnosis? So again, we go back to this slide, no? So sa sore siya, kasi ulcer yung presentation ng patient mo. Between painful, painless, so painless daw. So ito nilang yung choices mo. Pero ang clue mo is RPR, reactive siya. So RPR is a screening for your syphilis. Remember? Yung sa prenatal labs natin na discussion. So this patient probably has syphilis, no? So syphilis is a chronic complex systemic disease caused by Treponema pallidum. Okay? So it is considered early latent if it is within the past 12 months, more than 12 months, late latent. Meron din tayong syphilis of unknown duration. Okay? Pag hindi mo alam kung kailan siya na-incur, no? Kung within the past 12 months ba or more than 12 months. So, si syphilis, may stages siya. The first stage is called chancre, no? It presents as a solitary painless ulcer, just like what we saw in our patient. Second stage of syphilis is systemic na siya. Okay, so magkakaroon ka na ng rashes described as red macules and papules all over the palms and soles of the feet. And you will also have vulvar lesions. So in the vulvar lesions, you will see mucus patches and condyloma latum. Okay, so huwag kayong malito kay condyloma lata, kay condyloma latum. Sige, si condyloma lata, di ba, ano siya, medyo flat siya, yung appearance niya, no? So, mukha siyang condyloma acuminata, pwede siyang ma-mistake for condyloma acuminata, pero iba kasi yung itsura niya clinically, no? Mas flat yung surface ng latum, whereas pag condyloma acuminata, spike talaga, or parang cauliflower nga, yung growth niya ay pataas, no? Yung outgrowth ng lesion. So, parang, yung warts, parang spiky, whereas ito, flat, latum. Okay? Flat. Okay? So, the vulvar lesions are associated with painless adenopathy, lymphadenopathy. So, yung tertiary syphilis naman, this could be potentially destructive, no? So, mas bigger systems na yung ina-attack ng syphilis at this point. So, you could have CNS problems presenting as neurosyphilis, cardiovascular, pwede din, or pwede rin musculoskeletal yung manifestation mo. Meron din yung mga patients na gummatous lesions, no? Yung gummatous lesions, these are non-infectious granulomatous lesions found in the skin and bone. So, pag nakakita ka ng gummatous lesions in your patient, then tertiary syphilis na yung case ng patient mo. Okay, so transmission is via sexual contact or oral genital contact. The screening is through VDRL or RPR. Okay, so si patient natin, nag-reactive siya. So kapag halimbawa may patient ka na reactive for RPR or reactive on syphilis screening, anong next mo? You have to perform a confirmatory test. So these are your known confirmatory tests, no? FDA-ABS, MHATT. So magpo-confirmatory test ka after ka mag-positive sa screening test. So isa pang diagnosis or diagnostic is yung dark field, no? Pero hindi namin to masyadong in order. More of itong mga confirmatory tests for your syphilis. So on dark field microscopy, what you will see are thin, silvery, spiral, motile. Ito yung mga Treponema pallidum, okay, na motile organisms on microscopy. So ano ang treatment? Depende kung ikaw ay primary, secondary, tertiary, or kung ikaw ay early latent or late latent, or unknown yung duration mo. Okay? Pag primary, secondary, and early latent, you give 1 dose of benzathine penicillin, 2.4 million units intramuscularly. Pag late latent, you give it in 3 doses every week. Okay? So kapag meron naman ikaw neurosyphilis or kapag umabot ka na doon sa tertiary syphilis, mas matagal na yung gamutan mo, and we tend to give it via IV. Okay? So mas matagal yung cardiovascular na syphilis. Mas matagal dito yung duration. But for neurosyphilis, it's this one of 10 to 14 days yung regimen mo via IV. Okay? So going back to the question, isa-isay natin yung choices. IV penicillin is preferred due to her presentation. So ano ba yung presentation niya? Mukhang primary syphilis naman si patient. So no need to give IV penicillin. So pwede ng IM penicillin or intramuscular penicillin. A school of fish is seen on gram stain. So this is false because hindi naman to chancroid, painless solitary ulcer yung complaint ng patient. So si chancroid, di ba? Number 1 dyan, painless siya dapat. Painful siya dapat. So hindi siya to. Letter B. Tapos hindi rin siya treated with ceftriaxone because as you saw, penicillin yung ating drug of choice for primary syphilis. So, ang true lang dito is letter C. This is a case of primary syphilis. Okay? Meron siyang chancre, solitary painless lesion in your vulva. Okay. So, next, painless ulcer is your LGV. We call this LGV, lymphogranuloma venereum. So, this is caused by Chlamydia trachomatis, specifically your serotypes 1, L1, L2, L3. Okay? So it presents as painless ulcer or papule with or without inguinal and femoral lymphadenopathies. So how do you, ano yung diagnostic mo for this? You can perform aspirate or swab of the genital or the lymph node specimens, and you culture them or do direct immunofluorescence or nucleic acid detection. So, ang treatment for this is matagal, 21 days, 3 weeks at least, yan at least 3 weeks. So, for at least 21 days, iinom sila ng doxycycline to address this. The other painless ulcer is donovanosis or granuloma inguinale. Ang buzzword mo dito is that yung lesion niya ay beefy red. Okay? So, it initially appears as a symptomatic nodule which eventually ulcerates, causing this beefy red appearance. So this is caused by your Klebsiella granulomatis. So ito, in terms of histology, meron din siyang buzzword no, sa granuloma inguinale or donovanosis. Meron siyang Donovan bodies. So these are clusters of dark staining bacteria. Tapos kung papansinin niyo sa loob, meron silang tinatawag na safety pin or bipolar na appearance ng chromatin, no? Na-appreciate nyo, mukha siyang safety pin. Tapos kaya bipolar kasi yung magkabilang dulo is mas dark compared to the middle of the chromatin condensation inside the bacteria. So yan siya. Yan yung Donovan body. So safety pin. So beefy red, safety pin, donovanosis, or granuloma inguinale. So, ano ang treatment natin for granuloma inguinale or donovanosis? It's azithromycin. So, para siyang CLGV, matagal din yung gamutan, no? At least 3 weeks. So, si azithromycin, you can take it 1 gram orally once a week for at least 3 weeks until mawala lahat ng lesions. Alright? So, that's for your painless ulcers. Ayan. May isa pa tayong case. Wala na tayong case for vulvar ulcer. Now, we'll move on to the next chief complaint, which is vaginal discharge. So, common din yan, lalo na sa OPD. Vaginal discharge. Doktora, may kakaiba pong lumalabas sa puwerta ko. Okay, so let's look at the possible causes of your vaginal discharge. So, we have another patient. 33-year-old, G3P3, 3003. She came in for annual pap smear. Okay guys, ito lang, let me clarify something regarding this, no? Hindi pa to na-apply sa local guidelines, pero sa CompreGyne, ito na yung nakasulat. Na-report na rin to sa mga Gyne Onco conferences, but in terms of printed local guidelines, hindi pa ito yung nakasulat. But I would like to update you na in the latest na CompreGyne, the screening now starts at age 25 instead of age 21. Okay, in the previous editions of the book and in the local guidelines, what we follow is screening starting age 21. Okay? Now, ano na yung screening na dapat daw i-perform? If available, dapat daw primary HPV, meaning you test for the HPV high-risk types. Yung test na yun na yung gagawin mo instead of pap smear or co-test. Okay? And then you follow up the screening with HPV every 5 years. Kapag normal, syempre, yung prior screening mo. So, ganito na daw dapat mag-screen. But right now, ang ginagawa natin, if you still follow the local guidelines, annual pap smear pa rin, starting 21 years of age. Okay? So, yun yung ginawa nitong patient na to. Nagpapa-annual pap smear siya sa'yo. So, ayan, very good si patient nyo, no? So, mag-review muna tayo ng pertinent anatomy. So this is the endocervix, meaning nasa loob. Ito yung nasa loob ng cervical canal. Ito yung exocervix, meaning ito yung naka-expose sa vagina nyo. Okay? So magkaiba yung epithelium ng endocervix and your exocervix. Si exocervix or your exocervix, squamous cells yan. Okay? Pagdating mo sa endocervix, magiging siyang columnar cells. Ngayon, the junction between your endocervix and your exocervix, that's what you call the squamocolumnar junction, the SCJ. Okay? Kaya siya SCJ kasi abruptly magpapalit yan from a columnar epithelium to a squamous epithelium. Okay? So as the patient ages, yung dating squamocolumnar junction or SCJ, it would eventually evert out. Okay? So lalabas yan. So, dito na yung magiging original na squamocolumnar junction. Tapos, magkakaroon ng bagong squamocolumnar junction. Alright? So, ang transformation zone is actually the region between the current squamocolumnar junction and the original squamocolumnar junction. So, yan si transformation zone. So, dito nangyayari yung mga metaplasia, dysplasia, ganyan. So, kaya pertinent tong area na to. So, bakit ba, by the way, guys, nagpapalit ng epithelium? Kasi di ba, ibang-iba yung environment ng vagina with that of your endocervix, no? So, kaya nagpapalit ka ng epithelium from columnar to squamous. Okay? So, kung titingnan mo siya on speculum exam, magiging ganito siguro yung itsura ng iyong transformation zone. So ito, si original squamocolumnar junction. Tapos si new squamocolumnar junction mo is ito. Ayan. Tapos yung nasa loob is columnar, which is part of your endocervix. Yung mga nasa labas, squamous yan. Yung epithelium yan. So saan ka magpa-pap smear? Itong area dapat na to. Dapat ito yung mas sample mo. Dito ka dapat kumuha ng specimen for your pap smear. Yan. So when you perform your pap smear, you get from the endocervix as well as the exocervix, no? Making sure that you sweep around the transformation zone to get specimens from that area. And, however, nung nag-speculum examination ka, before ka pang makapag pap smear, you saw that there is pooling of milk-colored thin fishy discharge. Do you have an assessment for this patient? So ito yung abnormal discharge ng patient mo. So incidental lang siya, pero nakita mo siya on speculum examination. So this is the description. What is your assessment regarding this vaginitis of the patient? So this is most likely because of bacterial vaginosis, no? So pag sinabi mong mga vaginitis or vaginal discharge, ito yung usual three culprit mo, no? Bacterial vaginosis, trichomoniasis, and candidiasis. Si bacterial vaginosis, as I described a while ago, kasi bacterial vaginosis yung case niya, ito yung description ng discharge. Thin, whitish-gray, homogeneous, fishy discharge, no? So may amoy yung discharge siya. So probably hindi lang na-report sa'yo ng patient, pero meron pala siyang ganung mabahong naaamoy from her vagina. Si trichomoniasis naman, ang typical presentation niya is yellow frothy discharge with or without vaginal or cervical erythema. So ang typical description niya or ang buzzword niyo sa exam for trichomoniasis is strawberry cervix. So si strawberry cervix, para siyang may mga punctate lesions sa cervix. So mukha siyang strawberry. Si candidiasis naman, it presents as white, thick, curly discharge, no? So since thick and white siya and curly, ang description sa kanya parang cottage cheese, okay? Pero ang i-complain sa'yo ng patient mo is this one, the intense pruritus. Sobrang kate ng vaginal candidiasis. So what causes your bacterial vaginosis? When there is a change in your vaginal flora, such that nababawasan yung lactobacillus mo, you will get bacterial vaginosis. So on microscopy, you will see these clue cells, no? Ang clue cells ay epithelial cells that are studded by bacteria. Iba-ibang cause ng bacterial vaginosis. Basta essentially, nagpalit yung bacterial milieu ng iyong vagina, causing the decrease in the proliferation of your lactobacilli. So, kulang sa acid. So, nagpo-proliferate yung ibang bacteria, causing the characteristic vaginitis of bacterial vaginosis. Okay? So typically, ang culprit dito, kadalasan is Gardnerella. Okay? So yun yung sa bacterial vaginosis. So that's your trichomoniasis for you. So anong nagkukos ng trichomoniasis? It's your Trichomonas vaginalis. So ayan siya. Motile flagellated organism na makikita on microscopy. Okay? Si candidiasis naman, so it's a fungal infection. So depende syempre, iba-iba yung treatment natin for each type of vaginitis. Si bacterial vaginosis, it's oral metronidazole, 500 milligrams twice a day for 7 days. Okay? So uluin nyo to kasi madalas talaga tong na-diagnose sa OPD. So ito yung ire-reseta sa mga patient. Si trichomoniasis, metronidazole din, pero single dose lang of 2 grams ng metronidazole. Si candidiasis, pwede kang mag-topical na antifungal, yung nilalagay sa loob ng vagina. Pwede rin namang oral na fluconazole as a single dose, okay? Pero note lang guys, yung oral fluconazole, bawal yan sa buntis, okay? So we give topical antifungals for those patients. So sa candidiasis guys, when you put KOH, you will see the hyphae and the spores, okay? Sometimes we call this spaghetti and meatballs. Yun yung makikita mo. So, ito yung mga findings sa mga different kinds of vaginitis in your patient. O yan. Sige, isa-isahin lang natin. So, dun muna tayo, balik tayo kay bacterial vaginosis since ito yung case ng patient natin. So, we diagnose cases of bacterial vaginosis based on the Amstel criteria. So, dapat ma-fulfill niya 3 out of 4. So, ano yung 3 out of 4 na yon? Presence of thin, white or gray homogeneous discharge coating the vaginal wall. amine or fishy or odor noted with the addition of 10% TOH. So this is your whiff test. pH of greater than 4.5%. Kasi remember, may overgrowth ng ibang bacteria. So hindi na ganun ka acidic yung vaginal environment mo. So, nagiging basic. So, mas mataas yung pH. So, greater than 4.5 ang pH ng vaginal wall mo. And there is presence of clue cells, more than 20% of the epithelial cells. So, di ba si clue cells, pinakita ko kanina, para siyang epithelial cells na studded with bacteria. Ito siya. Ito si clue cells. Yan. Isang example ng clue cells. So those are your kinds of vaginitis. So if a patient comes to you because of vaginal discharge, yung tatlong yun yung mga tatlo sa top 3 differential diagnosis nyo, kumbaga. Okay? Now, may question pala ako. Guys, alin dito ang sexually transmitted? Okay? So sa kanila, sino yung kailangan mong i-treat yung partner? Is it BV, trichomoniasis, or candidiasis? So sa kanila, ang kailangan mong i-treat ang partner is the one with trichomoniasis. Okay? Si bacterial vaginosis, hindi naman sexually transmitted ang bacterial vaginosis. However, it's sexually associated. Anong ibig sabihin nun? So yung mga mas maraming partners or nagkaroon ng new partners, sila yung mas susceptible to having bacterial vaginosis. Sa candidiasis naman, so hindi naman din to sexually transmitted infection, but sino yung mga most likely nagkaka-candidiasis? These are your immunocompromised, yung mga diabetic or yung mga elderly natin, sila yung madalas nagko-complain ng vaginal pruritus na eventually we find out that they have vaginal candidiasis. Okay? So, yes. Kasi trichomoniasis yung sexually transmitted. Now, we move on to the next chief complaint, which is abdominal pain. So, madalas to, lalo na sa ER. Kung dumating yung patient sa'yo, it's either dinudugo or sobrang sakit ng tiyan. Yan yung chief complaint nila pag ikaw ay nag-duty sa ER namin. So, ano yung mga iisipin natin sa abdominal pain? So, bukod sa bukol, itong dalawa next to cases ko, yung mga other differential mo for abdominal pain. Kasi yung bukol, obvious na yan eh. So later on, matatakal ko yan when I discuss your ovarian new growth. Pero, for the purposes of our discussion, ito ay mga non-ovarian new growth concerns, okay? So hindi ito mga mayumas or hindi ito mga abdominopelvic masses. Okay, so first case. We have a 26-year-old na ligabid who came in for severe abdominal pain. She complains that this is cyclic. So every month daw to, usually occurring during the first few days of her menses. This is associated with painful bowel movement. So she has dyschezia and dyspareunia. So painful ang kanyang sexual intercourse during this time. Pertinent IE findings are as follows. Her uterus is retroverted. There is tenderness on the left adnexal area and she has nodularities in the cul-de-sac. So may consideration na ba kayo given the presentation of the patient? Because this is most likely a case of pelvic endometriosis. So what is pelvic endometriosis? In pelvic endometriosis, there is presence and growth of glands and stroma of the uterus in an aberrant or heterotopic location. So meaning, meron kang glands ng endometrium na nasa labas ng lining ng matres. So every time you have your menses, nagbe-bleed ka rin in other areas of your pelvis. Okay? So hindi lang sa loob ng matres, sa labas din. These are the prevalent theories behind the pathophysiology of your pelvic endometriosis. So the number one is retrograde menstruation. So meaning you spill out the endometrial glands and stroma coming from your endometrial cavity. Okay? So dun siya nanggagaling, retrograde menstruation. So instead na lumalabas sa baba, some glands and stroma come out of your fallopian tube filling out into the pelvic cavity. Okay? So another one of important note is lymphatic and vascular dissemination. So this is the reason why merong endometriosis in far-flung areas like your lungs. Okay, far-flung talaga. So ito yung sinasabi nilang reason kung bakit nagkakaroon ng pelvic endometriosis in those organs, no? Because of lymphatic and vascular dissemination. So sumasama siya sa lymphatics and sa bloodstream, kaya nakakaabot siya even sa lungs. Sometimes we find it sa legs, forearms, thighs. There are several case reports na on that. So these are the others, hindi ko nadadaanan isa-isa in the interest of time. But what's important to note is that ang pinaka-common na area for pelvic endometriosis is your ovaries. Okay? Diyan pinaka nakikita yung mga aberrant na endometrial glands and stroma. So we go back to our index patient, no? So ito yung summary ng case niya. She's a 26-year-old na ligavid with dysmenorrhea, dysplasia, and dyspareunia na cyclic, no? So this happens every month for her. So every time nagme-mens siya. So yun yung isang clue na pelvic endometriosis yan. So ito yung pertinent clinical findings sa kanya. And on imaging, we see a unilocular cystic mass. So kung titingnan mo yung loob ng kanyang cystic mass, merong ground glass appearance, no? So this represents the old blood, okay? So yung mga old blood clots yan, yung ground glass appearance. So yan yung classic description ng endometriotic cyst. So eventually, this patient, no, underwent surgery. So probably sobrang laki nung endometriotic cyst niya, sabihin na natin 10 centimeters. So this patient eventually underwent oophorecystectomy. Okay? Guys, hindi kailangan tanggalin yan, ha? Hindi kailangan tanggalin yung entire ovary plus fallopian tube, please lang. Bata lang tong patient. So, as much as possible, what we do is we perform oophorecystectomy. We just remove the cyst. So, upon removal of the cyst, this is what we see on cut section. So, you see that the cyst has chocolate brown fluid within. Okay? So, ano tong chocolate brown fluid na yan? Ito yung old blood na eventually broken down into hemosiderin. Kaya meron siya nitong classic color na chocolate brown appearance, okay, ng fluid. So, old blood yan. So, yan yung dati niya pang regla, okay? Now, we move on to the next case of abdominal pain. So, yun yung isa nating differential diagnosis. Pwede siyang may pelvic endometriosis. Okay. We have a 21-year-old na ligavid who presented at the ER with fever. So immediately you think of an infection and abdominal pain. Upon examination, she was noted to have foul-smelling mucopurulent vaginal discharge and pain upon manipulation of her cervix. So meron siyang cervical motion tenderness. Ultrasound showed a complex mass measuring 4 by 3 centimeters occupying the left adnexal area. So on ultrasound, you saw that the ovary was no longer distinguishable from the said mass. So itong dinidescribe niya dito na to, itong 4 by 3 centimeter complex mass na hindi mo na raw ma-distinguish from the left ovary, this is actually what you call a tubo-ovarian abscess. Anong difference niya kay tubo-ovarian complex? Si tubo-ovarian complex, madidistinguish mo pa yung left ovary from the tube. Ganyan. Pero ito, hindi mo na daw ma-distinguish. Therefore, this is an abscess na. Labo-labo na yung mass na yan. Hindi mo na alam kung alin yung ovary, alin yung fallopian tube. Basta isa na lang siyang malaking nana. Okay? So this is a case of pelvic inflammatory disease. Bakit? So una sa lahat, na-fulfill niya yung 2 sa 3 minimum criteria. So ano yung minimum criteria? Lower abdominal tenderness, adnexal tenderness, and cervical motion tenderness. So ano ibig sabihin mo ng minimum criteria? Meron ka lang isa sa 3 nito and have in the background of having high index of suspicion, you may already treat the patient for PID. Okay? So what are your additional criteria for diagnosing PID? So ano yung mga supporting criteria? Yung mga naka-red, ito yung present sa patient natin, no? So oral temperature greater than 38 degrees Celsius, abnormal discharge, presence of WBCs on microscopy of vaginal secretions, elevated ESR, CRP, and laboratory documentation of chlamydia or gonorrhea. Since ito yung mga common etiologic agents mo for PID. Okay? So kung ito yung minimum criteria and additional criteria, ano yung definitive criteria na pag nakita mo to, PID to, matic. Okay, so ito yung definitive criteria natin. First is the histopathologic evidence of endometritis on endometrial biopsy. I'm telling you guys, medyo mahirap to ma-isolate, pero this is the first definitive criteria. Second is a transvaginal sonography or MRI showing thickened fluid-filled tubes with or without free pelvic fluid or tubo-ovarian complex. So ito na-fulfill actually to ni patient, no? So mukhang yung complex mass na to, most likely, ito yung dinidescribe niya, yung transvaginal ultrasound picture ng PID. So kung titingnan niyo tong picture na to, we have a clue na ito ay tubal pathology because may incomplete septation siya. So pag sinabi mo yan, pag nakakita ka ng ganyan, incomplete septation, likely what you're looking at on ultrasound is a picture of a fallopian tube that is fluid-filled. Typically, hindi mo makikita ang fallopian tube mo on ultrasound, pero kapag halimbawa siya ay infected, may lamang tubig, or may lamang blood, may lamang nana, dun lang siya mag-show up. Okay? And when they do show up, they will show up with cogwheel appearance like this, no? So para siyang may incomplete septation. So the third and final definitive criteria is having a laparoscopic abnormality that is consistent with PID. So guys, ano to? So guys, ano muna tong organ na to? So this is your liver, and these are perihepatic adhesions towards your abdomen. So this is what you call Fitzhugh-Curtis syndrome, no? So kung papansinin nyo, when we perform surgery on ectopic pregnancy. Diba ang ectopic pregnancy, pwede siyang makos ng PID, pwede yun yung underlying cause niya. What we do after we perform salpingectomy and we ensure na may hemostasis na, we palpate the liver. So this is what we're looking for when we palpate the liver. Okay? Because having palpated this, ibig sabihin, meron ka talagang PID, no? You either have chlamydia or gonorrhea infection. So, yan siya. Isa siya sa mga pathognomonic signs natin na meron kang PID. And that's what you're really dealing with is PID. So yan, Fitzhugh-Curtis. So doktora, lahat ba ng cases ng PID kailangan namin i-admit? No. Not all cases of PID ay ka-admit-admit. Meron tayong OPD regimen for PID, but for this lecture, I will focus on the ones that need hospitalization. So these are your criteria for hospitalization. So first, if surgical emergencies such as your appendicitis cannot be ruled out. Second, in the presence of tubo-ovarian abscess, which is present in our patient. Third, kapag buntis yung patient mo. Fourth, if there is severe illness causing nausea and vomiting or high fever, so this is present in our patient. The fifth reason is if she is unable to follow or tolerate an outpatient oral regimen. And finally, if there is no clinical response to oral antimicrobial therapy. So these are your criteria for hospitalization. So anong gagawin mo pag na-admit mo sila? You give this, no? You give your IV regimen for PID. Okay, so after giving your IV regimen for 48 hours, you will reassess the patient. So saka ka pwedeng mag-shift to oral medication. So kailan mo sila ino-operahan? Yung iba po kasi doktore, parang nag-oopera sila ng PID. Okay, not all cases of PID are operable. So nag-oopera lang tayo kapag may life-threatening infection, nag-rupture na yung abscess, there is cul-de-sac abscess kasi mahirap tong ma-address with IV antibiotics lang. There are persistent masses in patients with completed family size and persistence of symptoms. So mag-iiba siguro ang usapan natin kung meron tayong 49-year-old na G5 na patient. So probably sa ganun, no, it would be warranted or it would be better for the patient if operahan mo na lang siya, tanggalin mo na yung focus of infection. Total, completed family size na. And if the infection has been recurrent or mahirap nang i-treat, you could opt to do total hysterectomy with removal of the affected na adnexa. Okay? Okay. So how will you manage this case? So PID na may tubo-ovarian abscess and with severe illness, I would admit this patient and give IV antibiotics. Okay? So, ano yung mga feared sequelae natin for this patient? So, ano yung mga i-appraise mo sa kanya now to watch out for in the future? So, she is high risk for having ectopic pregnancy, infertility, chronic pelvic pain, and pwedeng maulit tong another episode na to ng pelvic inflammatory disease. Okay, so speaking of infertility, that will be our next chief complaint. Infertility, my favorite. Okay, so ano ang definition namin ng infertility? Infertility is failure to achieve a clinical pregnancy after 12 months of or more of unprotected sexual intercourse. So infertility could either be primary or secondary. When you say primary infertility, it means that the woman has never been pregnant. So G0 talaga siya. Secondary infertility is when there is infertility in a couple following a previous pregnancy. So for example, G1, P1, 10016 patient, tapos hindi na nasundan, no? Matagal na nilang gustong sundan. 5 years na, hindi pa nasusundan. So we label that as secondary infertility for 5 years. Okay? Alright, so these are the different causes of infertility. So I'm showing this pie graph to you para ma-memorize nyo na. Kasi guys, ilang beses na lumalabas talaga to sa board. Okay? So ito ay galing sa Blueprints OBGYN. So ito yung table na very high yield. So isa-isahin ko siya for you guys kasi nakailang tanong na sila regarding this. So ano yung mga possible causes nyo ng infertility? It could be from a female factor, 45 to 55% female factor. Malaki din yung male factor, 35%. So yung mga unexplained infertility that comprises 10% of the causes of infertility, 10 to 20% pwedeng combination ng male and female factors of infertility. Okay? So again, guys, ilang beses to natanong kung yung mga percentages ng causes ng infertility. So kung ako sa inyo, i-memorize ko na tong infertility pie graph na to. Okay? Ito yung mga causes ng infertility. So familiarize yourself with this graph. And then, I'll leave that up to you. Move on na tayo sa next. Okay, now let's discuss the ovulatory causes of infertility. So you could have PCOS, kasi anovulatory ka, as I mentioned a while ago. Advanced maternal age from diminishing follicular count, premature ovarian failure. So ano ibig sabihin na to? Nag-menopause ka na at less than 40 years old. So, hyperprolactinemia and hypothyroidism, yung other ovulatory causes ng infertility. So, si hyperprolactinemia and hypothyroidism, they both inhibit your GnRH release. So, nasa H pa lang, sa HPO axis, na inhibit na niya. So, down the cascade, ayan, nag-aano na tayo, nag-fail na yung HPO axis. So, causes under tubal. So basically, anything that alters your tubal anatomy or your tubal motility can cause female factor infertility. So examples are your PID, BTL, or basically any surgery involving the tubes, pelvic adhesion, endometriosis. So si endometriosis kasi, meron siyang adhesion, no? Causing alteration in the anatomy and the motility of your tube. So kaya nagkakaroon ng female factor infertility secondary to a tubal factor or tubal cause. So under uterine, so mga distortions naman to sa uterine anatomy, congenital malformation, submucosal fibroid, polyps, Asherman. So ano yung Asherman? So Asherman syndrome is when there are adhesions in the endometrium secondary to, for example, a iatrogenic procedure like curettage. Okay? Tapos ito, wrong spelling, but luteal phase defect. So very rare naman to. Pero essentially, may problem ka sa luteal phase mo, which is supposedly, di ba, doon, yun yung phase where so finally, wrong spelling lang, but this is your luteal phase defect. So remember, during the luteal phase, your corpus luteum should be producing your progesterone. So during the luteal phase defect, may abnormality in your corpus luteum causing decreased amounts of progesterone. So because of this, hindi sila sustain or maintain ng endometrium that is viable for implantation of a fertilized ovum. Okay? So, cervical causes. So, ito mga obvious naman to. Cervical stenosis, makipot yung cervix. Cervicitis, infection of the cervix, and unfavorable mucus. Okay? So, these can cause your female factor infertility. Now, si male factor infertility naman. So, maraming causes ng male factor infertility. In fact, di ba, almost 1/3 or more than 1/3, in fact, are caused by your male factor infertility. So, importante to guys. Hindi lang yung female yung i-work up nyo, pati yung male. At the very least, what you check for is the semen analysis. So, ito yung normal values mo for your semen analysis. There should be at least 1.5 ml of ejaculate. Sperm concentration should be at least 15 million per ml. Total number should be at least 39 million per ejaculate. So iba to ha, ito is concentration. Million per ml, ito is the entire thing per ejaculate. The motility should be more than 40%. Ito iba siya sa progressive motility, okay? So progressive motility should be at least 32% and yung normal forms is 4%. Now, I highlighted something here sa male factor infertility, which is varicocele. Yung varicocele, ito, nire-refer namin to sa uro for correction, no? Ito yung sa on examination, may bag of worms, di ba? Sa testis ng partner. So, ito yung pinaka-common na correctable structural defect in your males na pwedeng i-address ng urologist. So, we also refer to our friendly urologist to manage cases of infertility if we see a male factor in infertility in our patients. Okay. So, ano yung basic workup mo for infertility? So, syempre, this is aside from yung mga infectious workup, yung mga pap smear, CBC, etc. Ito yung workup just for the infertility, okay? Focusing on the infertility. First is to rule out any structural cause. You have to order a transvaginal ultrasound, okay? Next is HSG. HSG stands for hysterosalpingograph. So in this study, you inject a dye into the uterus and then you take an X-ray after a certain period of time. So dapat, ang makikita natin is may spill ng dye sa bilateral fallopian tubes. So this will establish the patency of your tubes, okay? So syempre kapag patent yung tubes mo, then you have a good prognosis for pregnancy, okay? So, yeah, naglag ako, sorry. So, third is semen analysis to rule out male factor infertility secondary to sperm problems. And last is test for ovarian reserve. Now, test for ovarian reserve, usually we reserve this for patients who are at least 35 years old or kung may high risk ka na mabawasan yung ovarian reserve mo. So, kailan nangyayari yon? For example, meron kang surgery, prior surgery sa isa mong ovary. Okay? So, pwede ka magpa-test nun for ovarian reserve. Or, kung less than 35 years old ka, pero meron kang family history na nag-menopause, nag-premature ovarian failure at less than 35 years old, then sige, you're warranted. Pwede kang mag-test for ovarian reserve. So, what we do is date 2 to 3 FSH with or without your estradiol. Okay? And then your AMH. Anong maganda kay AMH compared with your SSH? Si AMH, hindi mo siya kailangan i-time sa menstrual cycle ng patient. Unlike ito si SSH na kailangan day 2 or day 3, kailangan saka ka mag-extract ng serum. Si AMH ay kahit any time sa cycle, pwede mo siyang i-take. So si AMH dapat mataas, si SSH dapat mababa. Okay? Bakit dapat mababa? Remember, di ba, when I was discussing with you the menstrual cycle, dapat to start lang mataas si FSH. Towards day 2 to day 3, bababa na yan kung meron kang follicles na nare-recruit that produce your estrogen. Kasi your estrogen will cause negative feedback kay FSH. So kung wala kang nagne-negative feedback kay FSH, then mataas si FSH. So ang gusto mo na result for day 2 to 3 is mababa na FSH. Okay, malinaw? Okay. So, let's focus again on the semen analysis. So, ito yung mga terms namin in terms of abnormalities in your semen analysis. Pag konti, yung concentration less than 15 million per ml, we call that oligozoospermia. Kapag abnormal yung forms niya, less than 4%, we call that teratozoospermia. Kapag hindi naman malikot yung sperm, then we call that actinozoospermia. Okay? So, paano, doktora, kung meron siyang motility na 3%, tapos 3 million lang din yung per ml yung kanyang semen, then meron siyang oligoactinozoospermia. Okay? So, konti na hindi malikot yung sperm. So, this will be the label for the abnormality. Now, take a look at the semen analysis. So, tingnan niyo yung concentration, 5 million per ml lang. Tapos, tingnan niyo rin yung motility, no? So, hindi malikot yung sperm. Tapos, 2% lang yung normal forms niya. So, paano natin isusulat yung diagnosis natin regarding the infertility? So, ganito siya. Primary infertility, then you write the duration. Primary infertility for 2 years. Secondary to female factor. And then, isasabihin mo kung anong klaseng female factor. So, you can say tubal. Kasi, di ba, take note, yung HSG niya, no, walang spillage of dye sa left fallopian tube. So, there is something wrong with the left fallopian tube. So, tubal and male factor. This is what we call OAT. So, na lahat ng abnormalities on semen analysis. So, it's konti, hindi malikot, and pangit yung forms. So, oligoactinoteratozoospermia. So, ito yung full diagnosis mo in terms of infertility.